Hi there, it's Dr. Suchard again, and in this clinical toxicology video, we'll be discussing the methylxanthines, corresponding to Chapter 63 in Goldfrank's Toxicologic Emergencies. The learning objectives here are that you'll be able to explain the mechanisms of action of methylxanthines and how these relate to potential serious toxic effects, and outline some of the less usual treatment options that may be employed for methylxanthine toxicity, as opposed to the symptomatic and supportive care that's general for all tox patients. First off, what are the methylxanthines? Well, they're a class of compounds all based off of xanthine, which have various numbers of methyl groups attached to them. This includes caffeine, 1,3,7-trimethylxanthine, theophylline, 1,3-dimethylxanthine, and theobromine. Caffeine was named after coffee, and theophylline was named after tea, so you'd think the theo and theobromine would also mean tea, but it's derived from a different word root. Here, theo means God, and theobromine means food of the gods, referring to chocolate and giving chocolate its proper and due respect. Caffeine and theophylline have been used as therapeutic drugs, but I'm not aware that anyone's done that with theobromine, which is why it's hazed out here on this slide. Theophylline had been a mainstay in the treatment of asthma and COPD for many years, but it's essentially become obsolete. Theophylline and the closely related aminophylline were super common when I was in medical school and residency, but it's very rare now that I see patients taking them. Basically, we've got other options and safer therapies. When theophylline was widely used, there were lots of patients with theophylline toxicity. The therapeutic index was quite narrow, such that it was hard to get a good clinical effect without getting up into the toxic range. And of course, if more people were taking the drug, there were more opportunities also for acute overdoses. Currently, most methylxanthine exposures occur with consumption of food and drink, with millions and probably billions of exposures around the world daily with coffee, tea, chocolate, and other more regional caffeine sources. Most of the serious toxic exposures to methylxanthines, and these are nearly always to caffeine, occur from various supplements promoted to improve alertness or for weight loss or to allegedly improve athletic performance. The big jug of 100 mg caffeine tablets on the right is particularly scary to me, since a fatal dose for humans is in the several gram range, so taking only a few dozen of these tablets could be bad. So how do methylxanthines work? What's their mechanism or mechanisms of action? Methylxanthines release endogenous catecholamines, and this results in increased beta-1 and beta-2 adrenergic stimulation. So in addition to beta-2's beneficial effect on obstructive pulmonary issues, we'd expect to see cardiovascular side effects like tachycardia and vasodilation. It was traditionally taught that methylxanthines worked primarily by inhibiting phosphodiesterase, such that intracellular cyclic AMP levels would increase, enhancing any endogenous beta-2 stimulation. And it's true that theophylline and the other methylxanthines can inhibit phosphodiesterase, but they only do so at toxic levels, so this might be a minor contributor at best. Methylxanthines are also adenosine antagonists at the A2 receptor. The adenine portion of adenosine is structurally very similar to the methylxanthines, explaining how caffeine, for example, could block adenosine receptors. And it's this action that results in CNS effects, the alertness we feel from caffeine. And when taken to an extreme, it's also responsible for an increased risk of seizures with methylxanthine toxicity. I found a great explanation for how caffeine works when browsing Reddit. Over the course of the day, your body produces adenosine, and as it builds up in the brain, you get more tired. Then when you sleep, the adenosine is cleared, and you start over again. Caffeine blocks adenosine receptors, so you don't feel tired. And if that was too wordy, or if I needed it explained like I'm 5 years old, caffeine makes sure your brain can't feel the sleepy dust. The table here shows a range of effects seen in methylxanthine toxicity. The worst, that is, the most dangerous manifestations, are various tachydysrhythmias, and the example shown here is multifocal atrial tachycardia, but many others including SVT, AFib, and VTach may occur, and increasing degrees of CNS overexcitation and seizures. As already mentioned, the brain releases adenosine, which binds to autoreceptors in a negative feedback loop. When neurons are firing as part of a seizure, adenosine is being released, and that adenosine builds up to a point where its CNS depressant effect promotes seizure termination. But if adenosine is blocked, that negative feedback doesn't occur, making the seizures harder to control. Getting back for a second to the tachydysrhythmias, these can be treated with an esmolol drip. And what's unusual here is that a beta blocker might still be indicated even if the patient is hypotensive. But think about the mechanism. The tachycardia and arrhythmias are due to excessive beta-1 stimulation, and the hypotension can be due to excessive beta-2 mediated peripheral vasodilation. Esmolol might be the best choice if you're going to use a beta blocker in this situation, since it has a very short duration of action. That's why the brand name is Brevablock, since its blockade is brief, allowing for titration and for ending the effect quickly if it doesn't help to correct hemodynamics. With regard to other methylxanthine toxicity treatment concerns, CNS excitation, agitation, and seizures should definitely be treated, and the recommendation is to use benzos or barbs. Benzodiazepines are often used first, but we've already heard that the seizures can be difficult to control, so the addition of or transition to barbiturates should be considered early. And although it's not used frequently anymore, phenytoin is contraindicated because it's ineffective for methylxanthine-induced seizure. There are a few potential methods to enhance methylxanthine elimination. Multidose activated charcoal can be given to act as a kind of gut dialysis, preventing enteroenteric recirculation, and both hemodialysis and charcoal hemoperfusion may be used. Now, the actual textbook chapter title isn't limited to the methylxanthines. It also includes selected beta-2 agonists. The overlap here makes some sense because beta-2 agonists, similar to theophylline, are used for pulmonary issues, and the toxicity profiles are quite similar, since the methylxanthines work mostly by stimulating release of endogenous beta-agonist catecholamines. But the inclusion of selected beta-2 agonists in the title is virtually the same as saying clenbuterol, which is not an approved drug in the United States, but is misused extensively for weight loss and body sculpting. It's easy to imagine someone using clenbuterol thinking that if some is good, then more is better. That's actually a pretty common scenario for clenbuterol toxicity. Alright then, I'm finished with my comments about the methylxanthines. I'll be seeing you around.